and the strategies in the guidelines to accurately identify patients with hereditary angioedema, analyze and compare approved and emerging treatment options for managing HAE effectively, and then to utilize shared decision-making and a validated assessment tools in the development of treatment plans for individuals with hereditary angioedema. So just a little bit about the disease. I'm sure many of you are very familiar with this. There's been a lot of education about it over the last 10 years at our national and regional meetings. So as you're aware, HAE is a rare, actually an ultra rare and potentially life-threatening disorder characterized by unpredictable episodes of swelling. These attacks can affect the skin, the gastrointestinal tract, and the upper airway. Obviously, timely recognition and appropriate management are essential to improving patients' outcomes. So how does this disease present? Well, it's recurrent, non-pitting, non-pruritic subcutaneous and submucosal swelling without associated urticaria or itching. It's an autosomal dominantly transmitted disorder. So typically patients, at least 75%, will have a family history. And we recognize three subtypes, HAE type 1 and 2, which has to do with C1 inhibitor deficiency in type 1 and dysfunction in type 2, with the net of both of those having not enough functional C1 inhibitor to regulate the kinin and kallikrein pathway. Then there's HAE with normal C1 inhibitor, where the C1 inhibitor levels are normal, but the symptoms that they present with the angioedema appears to be bradykinin mediated, as it is in type 1 and type 2 HAE. The attacks that these individuals have, and which is the manifestation of the disease, are variable in onset, although the majority develop over several hours. So it's not like a mast cell-mediated attack, which may occur and present over a period of minutes. The attacks are often prolonged with increasing intensity over 24 hours and may take 2 to 4 days to completely resolve. A clinical pearl is that it's unresponsive to antihistamines, corticosteroids, and epinephrine, helping you differentiate it from mast cell-mediated disease. And it's quite unpredictable with variable frequency and triggers amongst different individuals, even in the same family that has the same mutation. The commonly infected areas are the face, extremities, genitals, oral pharynx, and the gastrointestinal tract. The triggers typically are trauma, surgery, medical kinds of other things like dental procedures, emotional stress, estrogen, such as oral contraceptives or during pregnancy or even around menstrual periods, and also febrile illnesses. First symptoms usually occur in childhood or adolescence, with 50% of individuals presenting with their first swelling episode before they are 11 years of age. This is a little bit of a confusing slide, but basically shows the complement pathway and where C1 inhibitor acts in that pathway, and that's where it got its name, that it inhibits activated C1 inhibitor where that plus sign is and prevents it from that pathway from progressing. In the contact or kallikrein activation pathway, you can see that there's a variety of places where C1 inhibitor acts, both decreasing the conversion of factor 12 or Hageman factor to activated factor 12, which triggers the process. And if you go to the right side of the slide, the typical pathway is factor 12A liberates prekallikrein. Prekallikrein then creates kallikrein, and then kallikrein in combination with high molecular weight kininogen liberates bradykinin, which interacts with the bradykinin 2 receptor on the vasculature, causing vasodilation and vascular leak, leading to the localized edema that we see. You can see that there are other pathways to get there, if you will, and the variety of places where C1 inhibitor acts to regulate these pathways, and when absent, allows these pathways to run uncontrolled. It's important to differentiate between mast cell-mediated angioedema and bradykinin-mediated angioedema. Mast cell-mediated disease is primarily the type of angioedema we see in our practices, with over 95% of angioedema caused by liberation of mast cell mediators leading to vasodilation and swelling. In bradykinin-mediated edema, we've sort of looked at the pathway with basically lacking C1 inhibitors, so this contact system running unabated. The ways to differentiate between the two, I've sort of pointed out a couple. One is lack of urticaria, which typically is present in mast cell-mediated angioedema. lack of response to mast cell drugs that actually will treat mast cell disease, such as antihistamines or corticosteroids or epinephrine in an acute situation, and also the progression of the attack. Mast cell being relatively quick, as we've seen if someone has a reaction to an allergy shot or reports a reaction to a bee sting or a food that they've ingested that they're allergic to, as opposed to individuals that have bradykinin-mediated disease, where the swelling is much more protracted, slower in onset, and lasting a longer period of time. This is a classification of hereditary angioedema, and it looks a little bit complicated, but it's not really. We have HAE with C1 inhibitor deficiency at the top due to a mutation in the SERPINE1 gene, and there are now over 800 different mutations that have been identified in that gene that lead to either type 1 or type 2 HAE. Type 1 is more prevalent, with about 85% of patients having that type of HAE with C1 inhibitor deficiency. And C1 inhibitor dysfunction in type 2 make up about 15% of the population. The group below that in green, the patients that have normal C1 inhibitor associated HAE, are due to a mutation either in the SERPINE gene or some other gene, as you can see there. We've identified patients that have a factor 12 gain of function mutation, probably the most common, plasminogen being the second most common identified, angiopoietin-1 another, and kininogen-1. The last three are less frequently identified, and there are still groups of individuals where we don't know what the mutation is. If you're looking to do a genetic screening panel for patients with C1 inhibitor normal HAE, the first four, factor 12, plasminogen, angiopoietin-1, and kininogen, are usually included on the standard panels that you can order. The others are basically only done in certain laboratories around the world. So how do you make a diagnosis? Actually, it's quite easy for HAE type 1, type 2. Again, somewhat more difficult for individuals that have type 3, what used to be called type 3, now HAE with normal C1 inhibitor. But hopefully your the history will help you at least look in the direction. So individuals that have recurring episodes of their swelling of their skin, extremities, face, genitals, or unexplained abdominal attacks, cramping, issues with swelling and bloating, that when resolved, that nothing can be found on evaluation of the gastrointestinal tract. And then obviously individuals who have laryngeal swelling attacks. Again, clues, there's usually a family history, although as I mentioned, the mutations are de novo in about 25% of patients. Typically the onset is in childhood or adolescence, particularly around puberty. There are symptoms of recurring painful abdominal pain, upper airway edema, and again, as we mentioned a minute ago, no response to antihistamines, steroids, epinephrine, or omalizumab. Some patients have prodromal symptoms before a swelling, and then the lack of urticaria often differentiates this type of swelling from mast cell-mediated disease. So this is a little bit of a diagnostic workup, if you will. If you suspect bradykinin-mediated angioedema or hereditary angioedema, these are the three tests that we can get in the United States easily and are actually relatively inexpensive: a C4 level, a C1 inhibitor level, and C1 inhibitor function. If the C4 level is reduced, the C1 inhibitor level and function are reduced, then that's type 1. If an individual has reduced C4 but normal or elevated C1 inhibitor levels but a reduced function, that's type 2. And we usually recommend that the blood test be repeated just to be sure there's not a lab error done in the process of the original specimen. For individuals that have normal C4s, normal C1 inhibitors, and normal C1 inhibitor function, then genetic testing, as I mentioned, for one of the mutations that have been identified for HAE with normal C1 inhibitor is appropriate. So this is basically a little chart with how you differentiate between HAE type 1, type 2, with the levels being low across the board in type 1, low with function and C4 protein level in type 2, but with normal C1 inhibitor protein levels. Do these diseases, does type 1 look different from a type 2 from a clinical standpoint? No. They have the same manifestation of attacks, and everything is basically the same. It's just what's missing that causes the defect that's different. So genetic testing is available. What we don't know is all the different mutations that may cause HAE type 1, type 2, or HAE with normal C1 inhibitors. So it shouldn't be uh, relied upon as the end-all diagnosis of the disease. Obviously, if you know the genetic mutation of the parent, then you can test a child, and if they have that same mutation, even if they haven't had any manifestation of the disease, no swelling attacks, then you may be able to make the diagnosis. But as I mentioned earlier, we have good laboratory tests that are relatively inexpensive and are probably the way to start your search. Again, we are going to find other SERPINE1 or other gene variants in patients going forward. And as we do that, hopefully they will be incorporated into the gene panels that we use for the HAE with normal C1 inhibitor patients. So we recommend that once you've identified someone in a family who has HAE, that testing be done with other first-degree relatives, so grandparents, parents, siblings, their children, their grandchildren, to try to identify individuals that have this disease. Why would you want to do that? Well, a delayed diagnosis can certainly increase the morbidity and, frankly, the mortality, as well as decrease the quality of life and appropriate therapy for patients that have HAE. The first HAE attack may affect the airways or the abdomen and may cause asphyxia and death or unnecessary surgery. We've talked about what tests should be used, and then once you make a diagnosis, what should you do? Well, we recommend that everybody with HAE be prescribed an on-demand therapy to treat an attack when it occurs. And then after that, then consideration of preventive therapy if on-demand therapy isn't satisfactory. So how do we reduce the burden, not only the disease burden, but the treatment burden on patients and their caregivers? So one of the things that we've learned, and we used to think that this is just a disease of attacks, that when the burden of the disease was really the attacks. But what we've learned is in between attacks, there's significant disruption of people's life, a lot of anxiety, a lot of stress about when the next attack is going to occur, what type of attack is it going to be, will they have their on-demand medication available, will it work if they use it? What impact will the attack have on their ability to function in a job or in a school or in a family situation? So not only is the burden of attacks is listed down there as important, but also the burden in between attacks that patients have to endure is a big deal. Obviously, we know these patients, at least in the past, before effective preventive medication, really weren't able to take jobs that they might want or progress with their education like they might want, and oftentimes have modified their lifestyles in order to avoid the triggers that they've identified as causing the swelling attacks. This is a survey that actually was given to caregivers of individuals with HAE, and you can see on the left side of the slide different things that the percentage of things that the patient's caregivers had to do for the patients with HAE, like making some treatment decisions or being there to take the patient to an appointment or talking to the doctor or getting their medication ready for treatment or to provide the medication treatment for it, scheduling appointments, doing the household duties that the patient may not have been able to do themselves. And if you look on the right side of this slide, what sort of impact this had on caregivers, and you can see for the most part, around 50% of patients had to schedule around the patient, had to worry about an infusion or infection or injection taking too long, trying to coordinate with the patient's medication and being home when it was delivered, taking them to the hospital, being there and watching an unpleasant injection or infusion episode. So these things wear on not only the patient, but also the family members that have to take or help take care of the patient, and something we should inquire about when we're seeing the patients and try to mitigate if we can. So there is a relatively good test similar to the asthma control test called the angioedema control test that we can apply to patients to try to decide if their disease is controlled or not controlled. And you can see it's an easy test, 4 questions. How often do you have swelling? Has your quality of life been affected? How much has the unpredictability bothered you? How well is your angioedema control by your therapy? So very similar questions to the ACT for asthma. And it goes from not at all at 0 up to very well 4. A score of 10 or less or below 10 indicates a very poorly controlled disease. So you can use this easy test when a patient comes into the office to sort of get them thinking about the control that they've had of their disease and then be able to intervene if the control is not good. So one of the things that is as treatment that we might think about is avoiding the triggers, being able to decrease the frequency of attacks just by decreasing the triggers. So what are some of these triggers? Well, hormones, as I've already mentioned, particularly estrogens. Actually, other medications like ACE inhibitors are also drugs that we know can trigger an attack. Interventions from a medical or dental standpoint, endoscopy, tooth extraction, et cetera, is enough trauma to trigger an attack. Getting overly tired, minor localized trauma, respiratory infections, particularly if a fever is involved, and even stress, probably the number one thing that patients report as being a trigger for their attacks. Managing those things may well prevent or lower the frequency that the patient attacks endure. So what about treatment? There's basically 3 pillars of that. One is on-demand therapy, which I've already mentioned, basically something that the patient can take rapidly and ability to stop an attack fairly quickly to decrease the morbidity and potential mortality of the attack. We recommend by guidelines that patients, everyone with an HAE diagnosis, have an on-demand therapy to use and should have enough on-demand therapy to treat 2 or more attacks at any given time. We recommend that patients carry this treatment with them. Unfortunately, they don't because it's somewhat cumbersome, particularly in the old days when we just had injectable medications. We now have an oral medication, which may make that more easy. And then we have long-term prophylaxis to try to reduce the disease burden, decrease both attack frequency and severity that patients can take. Obviously, some individuals require that. Some individuals aren't interested in routine medication, but certainly a discussion about that is warranted. And then in the middle, we have short-term prophylaxis. And the point of this is to prevent attacks in situations where a trigger may be present that would cause an attack, like a medical or dental procedure, giving individuals something to use right before those procedures or those activities that would prevent them from swelling as a result of that exposure. As with everything, the treatment obviously must be individualized for the patient by their age or by their sex in the setting of women who may become pregnant to try to get the optimal results and normalize their quality of life as best we can. The recommendations from the Medical Advisory Board of the HAE guideline document is basically all attacks are available for treatment, regardless of where they are or how severe they are at the time that they first occur. And we recommend that self-administration is preferred simply because it allows for early treatment rather than having to go to a clinic or a hospital to receive treatment. That prophylaxis should be available both on a short-term basis, as we've already talked about, and then individualized on a long-term basis with one of the long-term prophylactic drugs. And I've mentioned a couple of them here when this document was initially written, but there are others now that we'll talk about later. We have found success using progestins and antifibrinolytics like tranexamic acid in patients that have normal C1 inhibitor, although there's limited evidence around their efficacy. And then having a discussion really at every visit with how the patients are doing from a quality of life standpoint, looking at their first-line therapies, their on-demand therapies based on their age, and again, making sure that there's not been some change in their medical care, addition of estrogens, addition of C1 of ACE inhibitors, et cetera, that might interfere or cause their disease to be more active. We have to say also that C1 inhibitor, just because we've known about it and used it for so long, is really the preferred drug in women that are pregnant or breastfeeding. So here's sort of the treatment availability timeline, if you will. In the dark green boxes are drugs that are used for preventive therapy, and in the light blue boxes are drugs that are used for on-demand therapy. You can see kind of paradoxically that the first drug that was approved in the United States was for preventive therapy and not for on-demand therapy. It was a C1 inhibitor agent given IV every 3 to 4 days, approved for individuals aged 12 or above. We then went almost 10 years before we had another prophylactic medication, and that was sub-Q C1 inhibitor. So less burden of treatment, no IV every 3 days, but still a subcutaneous injection every 3 to 4 days. Then the next year, lanadelumab was the first monoclonal antibody. It was approved age 12 and above, given every 2 to 4 weeks. And then in 2020, we had our first oral prophylactic therapy. In 2025, interestingly, this summer, and I didn't update this slide, we've had 2 new prophylactic drugs approved, one garadacimab, given every 4 weeks, and another drug, donidalorsen, given every 4 or 8 weeks. From the on-demand standpoint, a year after Cinryze, the C1 inhibitor IV was approved, we had a C1 inhibitor approved for on-demand treatment, along with a subcutaneous therapy called encalantide. Shortly after that, icatibant, a bradykinin receptor antagonist, was approved for individuals age 18 and above, and became sort of the #1 on-demand medication for adults because it was a prefilled syringe, a subcutaneous injection that the patient could give themselves. And then we had recombinant C1 inhibitor in 2014, an extension down to age 12 for encalantide also at that same time. And then, as I mentioned earlier, in 2025, just this summer, July, sebetralstat was the first oral on-demand agent now approved down to age 12 for treatment of attacks. So as you can see, it's been a little bit of a timeline here, but considering the rarity of this disease, we're really very fortunate to have this many options to treat these patients. This cartoon sort of shows where things work. You can see that C1 inhibitor replacement actually decreases the conversion of factor 12 to activated factor 12. It also decreases the feedback loop from kallikrein back up to factor 12 activation. It blocks actually cleavage or activity of plasma kallikrein and cleaving high molecular weight kininogen and producing bradykinin. Encalantide and sebetralstat work as plasma kallikrein inhibitors to block the pathway there. And icatibant blocks the interaction between bradykinin and the bradykinin receptor on the vasculature. So any of these things can block the progression to bradykinin or the action of bradykinin, stopping the angioedema attack. If we look at some data around this, C1 inhibitor replacement therapy showed, this is for the sub-Q replacement therapy, showed a decrease at the 20 units per kilogram dosage, a significant decrease in attack frequency, with attacks going from basically 4 attacks a month to about 0.5 attacks a month in that trial. The good news about the plasma drugs that we have used for HAE treatment, that there's been no conversion to HIV or hepatitis or human B19 virus reported with these drugs. If we look at the encalantide, which was a plasma kallikrein inhibitor that was subcutaneous, but unfortunately associated with anaphylaxis and therefore had a black box warning for not allowing self-administration, again showed significant improvement both in the treatment outcome score as well as the mean symptom complex severity compared to placebo treatment. This is data from the FAST-3 icatibant on-demand treatment trial showing that icatibant decreased attack frequency or attack severity by more than 50% within 2 hours, compared to placebo at almost 20 hours. Unfortunately, icatibant does cause some injection site reactions. Those are you familiar with it. It burns when it's injected and then causes some swelling, itching, and redness for a couple of hours after it's been injected. But even because, in spite of that, it's the number one on-demand medication used in adults for HAE attacks in the U.S. currently. This is the data from the new drug, sebetralstat. And in the gray bar is on the far left is the placebo, and then the 2 doses of sebetralstat, 300 to 600 milligrams. And you can see that within 2 hours, more than 50% of the patients on sebetralstat are starting to report beginning of symptom relief, which essentially says that the progression of the attack has stopped. You can also see basically the same data that the severity is also down in 50% of the patients by at least 1 notch, severe to mild, or to moderate, or moderate to mild, or mild to none, within 4 hours of treatment. And then complete resolution, you can see that's also quicker with sebetralstat than the placebo. The dose that was approved by the FDA was the 600 milligram dose, even though both of them worked about the same in the trial. Turns out that there was less use of rescue medication in the 600 milligram dosage group, which isn't shown on this slide, but the FDA thought because of that, that was the appropriate dose as opposed to the 300. So what about prophylactic therapies? We have now, lanadelumab, which we've talked about previously, is a plasma kallikrein inhibitor, as is berotralstat, the oral plasma kallikrein inhibitor. We have C1 inhibitor replacement. We've talked about that in the timeline, either sub-Q or IV. And now we also have a drug that acts to decrease or interferes with factor 12, activated factor 12. And we also have a drug that, again, is not shown on this slide, that degrades prekallikrein. So if you don't have prekallikrein, you can't make kallikrein, and the cascade can't go forward. The garadacimab and this donidalorsen, which is the prekallikrein limiting drug, were just approved 2 months ago. So if we look at the COMPACT trial, which was the trial with subcutaneous C1 inhibitor, if you look at the where it says CSL 830, 60 IU or 60 international units, you can see that almost 40% of the patients did not have any attacks, and another 40%, or actually almost 50%, had mild to moderate attacks, compared to the placebo group, which basically 69% had severe attacks, either both in the low volume and high volume placebo, and almost no patients had no attacks whatsoever. This is data from the HELP trial, the lanadelumab trial. And again, on the left side of the screen, you can see that patients, let's look at the middle patients, the patients are the 300 milligrams every 2 weeks up at the top there. And you can see that placebo patients had on average 1.25 attacks a month, where patients on the 300 milligrams every 2 weeks had basically the placebo had almost 2 attacks per month, where patients on the 300 milligrams every 2 weeks, which is the recommended starting dose, had about 0.25 attacks every 2 weeks. There was about an 85% decrease in attack frequency compared to placebo. And the same thing was seen with severity that you can see on the right side of the screen. This is data from the oral plasma kallikrein inhibitor berotralstat. This is looking at attack rate by month, and you can see that in the green, and these are 2 different doses. The 150 dose is the recommended dose. The 110 dose was also studied in the trial. That within the first month, that there's a decrease of about 50% in attack frequency, but compared to the placebo patients, and that's maintained through the 6 months of the trial. Berotralstat is a drug that's taken daily. It's recommended to be taken with food. And in about 30% of the patients, at least for the first couple of weeks or month, they may experience some GI side effects, which can include abdominal pain, gastroesophageal reflux, diarrhea, and vomiting. This is data from the garadacimab, the factor 12A inhibitor that was approved this summer. And again, on the left side of the slide, you can see the change in attack frequency between the placebo-treated patients, which was around 2 attacks a month, down to essentially no attacks a month in the patients that were on garadacimab. And both the mean and the median is shown here. On the right side is a responder analysis looking at and basically stating that in the trial that 62% of these patients were attack-free for the whole 6 months of the trial, and at least up to 95% of the patients had a 50% or greater decrease in attack frequency compared to what you see on the placebo group next to it. This is data from the donidalorsen, the prekallikrein mRNA antisense trial. And again, looking what this drug does is actually depletes prekallikrein by presenting a missense mRNA so that the good mRNA doesn't allow protein production of prekallikrein. And it takes a few weeks for the prekallikrein that's circulating to be depleted, but once depleted, then they're showing an over 95% decrease in attack frequency at sort of at steady state. They tested this drug also not only at every 4 weeks, but every 8 weeks, and showed out at 6 months that the every 8-week dosing interval was as good at decreasing attack frequency as the every 4-week attack things. And you can see over on the right side, again, a responder analysis looking at change in attack rate with 53% of patients in the 4-week group being attack-free for the duration of for the actually starting at after 4 weeks through the rest of the study, 35% in the every 8 weeks, and then you can see the other percentages for attack reduction there. In this case, it was a very safe drug. The most common adverse events were injection site reactions, headache, and runny nose. And most of these were mild or moderate in severity. So what about investigational therapies? Not that we don't already have enough great therapy for this drug. Well, there's actually 4 that are in the pipeline right now. ADX324 is a short interfering RNA drug for long-term prophylaxis. It's in phase 3 and recruiting currently. I don't have a slide to show you about its results in its early trials. Navenibart is a YTE-modified monoclonal antibody which inhibits plasma kallikrein, so it's a long-acting lanadelumab, if you will. It's also in phase 3 and recruiting. Deucrictibant is a new oral bradykinin receptor antagonist, so it works like a icatibant, but it's an oral. They're looking at it both for acute treatment in phase 3 and also long-term prophylaxis. It's also in phase 3. The NTLA 2002 is an interesting drug. It's an in vivo CRISPR gene editing mechanism of action, basically knocking out the KLKB1 gene, which is the gene that produces prekallikrein protein. So working similarly to donidalorsen, but doing it in a more permanent fashion. It's hopeful to be a one and done treatment for these patients, and it's now fully enrolled in phase 3, and hopefully we'll have data sometime next summer on its effectiveness in the phase 3 trials. So more to come. This is basically showing what we have now and then what's coming in the pipeline. And you can see some of the same targets are being hit. Prekallikrein is being hit again with NTLA and ADX324. Navenibart hits plasma kallikrein as lanadelumab does. And deucrictibant is working down there at the bottom, hitting the bradykinin 2 receptor like icatibant does. This is data from the navenibart phase 1b/2 trial, and you can see there's 3 dosing regimens in this trial. There was a cohort that took 450 milligrams at day 1 and then was followed for 6 months. There was a cohort that took 600 milligrams at day 1 and then 300 milligrams 3 months later. And then a cohort that took 600 milligrams on day 1 and then repeated that dose at day 28. And you can see that in cohort 2 and 3, there was essentially 100% decrease in attack rates. We're looking at median data here. In the individuals that took the 450 milligram once and then were followed for 6 months, there was a 95 or 94% reduction in attack frequency, both at 3 months and 6 months, with the promise that this drug may be able to be administered every 3 months or even every 6 months, and maintain good control of HAE attacks. This is data from the Decryptobant on the phase 2 preventive study. And again, you can see on the left side of the screen, there was about an 84% reduction in the mean attack frequency at both the 20 and 40 milligram dosage compared to placebo. The same sort of data was seen in treated on-demand attacks as well as in moderate to severe attack decreases. So again, this data for this oral is almost as good as the subcutaneous drugs that we've been talking about as far as being able to decrease attack frequency by more than 80%. This is data, and it's kind of hard to see on the CRISPR-Cas9 in vivo. This is the phase 1 study. Basically, they were able to show at each of the doses that they gave, 25, 50, and 75, that there was about a 95% decrease in attack frequency across the board. They've selected the 50 milligram dosage as their go-forward dose in phase 3, and that's what's being used currently. Interestingly, there were no serious adverse events observed. They had a good knockdown of plasma kallikrein because this is basically knocking out the KLKB1 gene, and so no pre-kallikrein, so no kallikrein. So without kallikrein, you can't make bradykinin. So they had a very nice response across all treatment levels. So what about sort of some practical recommendations? Obviously, individualized therapy. All patients need an on-demand treatment. We should consider long-term prophylaxis with patients that have a significant burden of disease from their HAE. We still recommend short-term prophylaxis, even with patients that are on long-term prophylaxis before procedures that might trigger an attack. And self-administration is pretty much vital, particularly for the on-demand therapies, to allow patients to treat early and as often as they need to if an attack occurs. I think we're all familiar with shared decision-making, where basically we talk to patients and try to discover what their needs and goals are and what they're willing to do, if you will, and then discuss with them the alternatives of treatment and make sure that those treatments that we talk about are lined up with their goals, and then try to come up with some sort of an informed preference that the patient can make, and then a decision based on the information that we have, and obviously that circle can go round and round as treatments are developed for these patients. This is just another slide on sort of optimal care, shared decision-making being key to this, with taking in patients' values and preferences, the social determinants, as well as scientific evidence about the treatments to try to come up with the best treatment for the patient at the best time. All patients with HAE should have an action plan, and the components of that should be what medications are they going to use and when are they going to use them, when to seek emergency care if the medications aren't working in the setting or in the setting of a laryngeal attack. We recommend that patients treat and then go get close to an emergency center so that they can be seen if the treatment is not effective and they need to have their airway protected. How to administer the medication, so training of both the caregiver as well as the patients, having the patients make sure they understand the signs of an attack and maybe the signs and symptoms of a prodrome, and then a plan for travel and for what are they going to do with their medications if they're traveling for work or school or other things. So now I'd like to turn the presentation over to Dr. West, who's going to present a real world case that I think has some very interesting components to it. Brett?
Great. Hi, thank you, Dr. Lumry. Thank you so much for that excellent presentation over HAE and available therapies. So for tonight's presentation, we thought instead of taking a patient like previous webcast series who's newly diagnosed with HAE, thought we would maybe also present another clinical scenario that sometimes we often see, where somebody has known HAE and is on maybe a historical therapy who's thinking about switching to something new. So with that being said, I'm just going to present a patient from our office. She is a 64-year-old woman with a known history of HAE type 1. In her current condition, she was, as I said, transferred from an outside office for continued HAE management. But her story is that she had peripheral swelling since around age 30. She had an occasional abdominal attacks, but no real laryngeal attacks. Her attacks were often stress-related and preceded by a red non-urticarial rash, and her symptoms were slow to resolve despite steroids. And again, this is kind of her history here. So she was diagnosed with HAE in 1993, and at that time started on one of the standards of care with daily danazol, which really improved her symptom control and reduced her attacks to the point where she was able, over the course of a year or so, able to be tapered to danazol 3 times per week. As time went on, she was prescribed C1 inhibitor in 2009, and then once available, icatibant for acute attacks in 2010. Along the way, though, she remained on her danazol, and it was known that she had polycythemia on her lab monitoring, which, of course, is suspected to be a product of her danazol management. Other things, as mentioned before, polycythemia, so we would monitor her red blood cell counts on a regular basis. She would do blood donation at least once a year to help balance things out. We would watch her liver enzymes. They bounce between around the upper limit of normal to maybe sometimes a little above. And she would have annual ultrasounds for tumor surveillance. And then also listed here are her labs, which confirmed her diagnosis of HAE. Her other past medical history is remarkable for hyperlipidemia, hypertension, reflux, and allergic rhinitis. Her regular medications were Flonase, pantoprazole, pravastatin, hydrochlorothiazide. She had no known drug allergies. And then her surgical history was remarkable for tonsillectomy when she was younger in 1974. And then she actually had 2 vaginal deliveries in 1981 and 1985 without swelling events. Her events started not long thereafter, though. So I guess at this stage, just kind of wrapping up her overall presentation, we have a woman who's 64, who historically has been well managed on her danazol, but obviously with some potential downsides to that chronic management with her polycythemia and watching her liver enzymes, who is interested in maybe trying a new therapy.
And I also thank you for that great presentation, Brett. I also think there was an issue with her lipids, that obviously the danazol can increase lipid levels, particularly LDL lipids, and that was a concern as well for us. So I'm going to let you keep going here.
All right, here we go. Well, thank you. Her family history is remarkable for a sister with swelling, but otherwise a negative family history. Otherwise, she had 2 children, 21 and 17, who were fortunately unaffected by HAE. Other things here, her review of symptoms were negative, except for as noted in her history. Her vitals were reassuring, although her blood pressure was a little high, which was trying to be managed with thiazide. Her exam overall pretty well appearing. Her eyes had clear conjunctiva. Her nose, her inferior terminals were a little bit swollen. As mentioned before, she does have a allergic rhinitis as well. Her throat was unremarkable. Her lungs were reassuring, and her skin had no urticarial angioedema or striae, which we would look for somebody on chronic danazol. So overall, I guess we'll keep rolling here, but not a lot has changed with the last few slides as far as her circumstance.
Yeah, she also had some degree of hirsutism. She had some facial hair. She had sort of thick bones. Again, I think a result of the years of danazol that she took, even though she was on relatively low doses.
Good deal. So for our first audience polling question, what change, if any, would you make to the patient's current on-demand regimen? And I'll read the answer choices, and then we'll let our audience answer, and then we'll discuss them. So Option A, switch to encalantide. Option B, switch to sebetralstat. Or option C, no change. So we'll give you a few moments to answer that, and then we'll review the options. All right. So here we go. So yeah, I think we had some good answers here. The majority of folks are selecting sebetralstat, with a small percentage also thinking that no change is indicated, and nobody took encalantide. And just to kind of address that one, I think they're spot on. So of course, the encalantide comes with the significant downside of needing to receive the medication in a provider's office or at a hospital. So that obviously would create a barrier to care and a delay in treatment. Sebetralstat, I think, is, of course, an excellent option. It's, quick, it's oral, it doesn't sting, it's very effective. And then as far as no change or sticking with icatibant, that's some people's preference, and that's the world. Maybe they've used it before and trust it and don't mind the sting. But that's why I think there are both, acceptable options, but perhaps these days most people would like to try the oral agent.
Go to the next one. Let's see if I can get this to advance. Here we go.
All right.
So
So Larry, any further comments on that, Dr. Lumry?
no,
Or
I agree with you completely. I think the sebetralstat is in that oral option from the standpoint of allowing very early treatment, allowing easy transport and accessibility to the drug, the lack of any significant side effects that were reported really make it a great choice, and probably are going to create essentially a paradigm shift in how patients think about treating their attacks. We know with icatibant, because oftentimes patients don't carry it or are afraid to use it because they think the attack might not be as bad as the side effects from the drug, won't use it. We know about 60% of patients say they don't treat all their attacks. And some of that may be because of the drug that they have had in the past to treat it with. And also they don't treat early. The average time to treatment with the icatibant is out at about 2 hours, where in the open label extension study with the sebetralstat, it's about 10 minutes from the onset of symptoms. So hopefully that early treatment will decrease the morbidity of the attack and allow patients to be able to go on with their lives rather than having to go home to get a treatment and then wait for things to calm down.
yeah, those are excellent real world points. And then the other thing I like to add is as we roll into kind of the prophylactic decision making for this patient is, a part of her thing was that she didn't want to influence insurance changes for her or her her place of employment. And so that's why she held on to the danazol so long. And then also, as we know, a lot of our patients, in addition to, you know, their kind of delay in treatment, sometimes they run the calculation of, well, if I use my icatibant or my on-demand therapy now, will I have access to another one sooner than later? And so unfortunately that's a part of the world that we live in. But something to consider as well and discuss with patients.
Absolutely.
All right, so moving on to our next question. What change, if any, would you make to the patient's prophylactic regimen? All right, option A, switch to C1 inhibitor. Option B, switch to lanadelumab. Option C, switch to berotralstat. Or option D, no change. And so we'll give our audience some time to respond, and then we'll discuss the options. All right. Here we go. So we have kind of a potpourri of responses here. And again, I don't think any of these are wrong answers. Some may be more right in certain clinical scenarios and for the patient's preference. So just kind of looking at the options. So option A, switch to C1 inhibitor. So nobody actually took this option. But on the one positive I could see is it would maybe allow somebody to stop their danazol and therefore the side effects associated with that over time. The downside is you would need to give it subcutaneous every 3 to 4 days. So it's a bit of a treatment burden, I guess we could call it. Looking at option B, lanadelumab, I think this would be a very nice option. It's given subcutaneous every 2 weeks, and if you haven't had any attacks or problems after 6 months, it can be spaced out to every 4 weeks. So that would obviously be an upgrade from danazol. Option C, berotralstat, is a oral agent that is given daily and also would, alleviate a lot of the issues with chronic danazol use. And then finally, option D, no change. We had a small percentage of patients who kind of maybe, or our audience who think that maybe, well, it's working well for her, but maybe she shouldn't change. And that's a discussion to have. And there are dynamics that go into that. But overall, I think actually switching to perhaps either B or C might be best suited for our patient. And then Dr. Lumry, open to any other additional input you have.
Yeah,
on.
I mean, I would agree with that, Brett. I think that certainly danazol is a second line drug now. It's not specific for HAE. It works by actually increasing the output of C1 inhibitor from the functioning gene in the cell, in the hepatocyte. At least that's what we think is happening. But again, it's fraught with so much in the way of side effects that I think it's really something that, if nothing else is available, we should consider it. But now that we have many other drugs that are more effective and safer, that switching to one of them really makes the most sense for this patient.
And the only other thing I should add is that, of course, we have options here, but and when we were making kind of her treatment change was prior to the 2025 summer bonanza of HAE with all the options now. But still, these were the options available to her last year, and we were having this discussion.
Right.
All right, so we'll move on to our next slides.
Get it to go that we talked about it.
There we go.
Okay.
All right, so her treatment plan. So our patient chose to start prophylaxis with berotralstat after discussion of options. And as kind of mentioned before, there were some delays in her switching to a different prophylactic agent due to insurance concerns and the way it impacted her work insurance. But once she, went on to age 65 and hit Medicare, options were back on the table for her without significant consequences to her place of employment. All right. So with our next question, what type of required going forward? It would be A, annual liver ultrasounds, B, routine hematologic monitoring, C, annual pulmonary function testing, or D, no monitoring needed after discontinuation of danazol. So we'll give our audience a chance here to respond. Okay, so there we go. So I think we have some good answers here. We have most people answering B or D, which I think are both acceptable in this scenario. So if we just kind of go down the list here, once we're on established on the berotralstat, I think that annual liver ultrasounds, especially if they had been normal in the past and their liver function studies were reassuring that we can probably not need the annual liver ultrasound. So nobody took that answer. Option B, routine hematologic monitoring. This might be reasonable with a patient who's had, like ours, a history of hyperlipidemia and polycythemia. You just want to make sure that things return to baseline and maybe there wasn't some other input into what was causing that. So I think that is reasonable for amount of time, but not necessarily indicated for berotralstat by itself. As far as answer C, annual pulmonary function testing. So we don't typically think of this for patients on danazol for HAE, but as I understand it, danazol is also an off-label treatment for idiopathic pulmonary fibrosis. And if one is on that for that condition, then of course that would be indicated, but not necessarily for HE. So I think this was just kind of a distractor answer. And finally, option D, no monitoring needed after discontinuation of danazol. And I think once one is transitioned fully to berotralstat, then I think that's acceptable. I know that there are some associated GI side effects with berotralstat, but once one has discontinued the danazol, then really there's no necessary lab monitoring that is indicated. Any additional input on that, Dr. Lumry, or
Yeah, no, I think that those answers are absolutely correct, and your discussion was spot on. There is some data around increase in liver function tests with discontinuation of an attenuated androgen like danazol, which usually occurs at about somewhere between 2 and 6 weeks after it is discontinued. So it goes back to normal once it sort of bumps up, if you will. And if we were to draw a liver function test at 4 weeks after starting berotralstat, one might be concerned that the berotralstat was actually causing the liver function abnormalities, which it probably is not in that case. That was actually a concern in the clinical trial. But now we've seen that patients that have just been discontinued on their androgen actually can experience a slight rise in their liver function test just as the liver readjusts, if you will, without the androgen being present. But I agree with your discussion, Brett. Oops. So what are we doing here? So just to kind of wrap things up tonight, I think hopefully the key points that you took from our presentation was that early diagnosis is essential to ensure appropriate treatment and obviously improve disease outcomes. That first-line diagnostics for allergists should be a C4 level, a C1 antigenic level, and a C1 inhibitor function. If the results are normal, then certainly looking for C1 HAE with normal C1 inhibitor with genetic testing for a therapeutic trial may be indicated. That the treatment should obviously decrease the disease burden, the disease impact on patients as well as their caregivers with on-demand therapy for all patients and then prophylactic therapy as needed. The treatment landscape continues to evolve with increasing options as we discussed, basically decreasing the burden of treatment by increasing the interval between injections and introducing new mechanisms of action for patients that don't respond to other drugs that have maybe a different mechanism of action. And obviously, just like with all things that we treat, HAE management should be personalized based on attack frequency, severity, and obviously the patient's preferences. So with that, we'll open it up to Q&A, which I think we can either do through the chat or I don't know if we can open up your mic at home to ask a question verbally, but happy to take questions now.
There is one question in the Q&A box. Are you able to see it?
I am not.
Okay.
So could you
It's
read
okay.
it?
I can read it out loud.
Yeah.
So the question states, are there any outside resources that are specifically targeted at helping our adolescent patients with HAE navigate its challenges?
I'll take a crack and then I'll let Brett also weigh in. Through the Hereditary Angioedema Association, which is probably the best patient advocacy organization in the country, there are incredible resources on their websites for children and adolescents. They also have an adolescent program that's involved with the biannual summits that they have with patients attending, where they're getting kids involved not only in advocacy but also letting them know that they're not the only person in the world that has this disease. So I would look at the Hereditary Angioedema, it's HAE.org website, and you'll find excellent resources there for education of these patients that they can understand, as well as education for their parents. Brett, have you seen other resources for specifically the sort of difficult adolescent age group?
I was going to agree with you on the HAE. I haven't been aware of anything close to as good as the HAE and the amazing job that they do. But yes, I've attended the summit and then also attended some of the national meetings or the fun runs that they've done. And it is nice to kind of gather with others with this condition, and then also to let families who maybe have a child or adolescent who doesn't have parents with this disease, and they're the first one. It's nice to know others that have this, and to feel supported and be able to experience those resources as well.
One thing about treatment, one of the unmet needs that we've had is easily accessed therapy, on-demand therapy for the adolescent age group. As Icatibant, which, as I mentioned, sort of the most commonly used on-demand treatment for adults, is not approved under the age of 18. So the kids under 18 were, if you will, stuck with either using an IV C1 inhibitor, either plasma-derived or recombinant, or which requires obviously starting an IV every time you have an attack, or encalantide, which, as we mentioned, has a boxed warning to be given by a healthcare professional, either in a clinic or having a nurse come out to the house and provide the therapy and observation after the therapy. Now that sebetralstat has been approved, it is approved down to age 12. So that at least the 12 to 18-year-olds or 12 to 17-year-olds now have an easily administered, hopefully easily accessible medication that they can carry with them and take discreetly if they should have the beginning of an attack to try to stop the attack early. So and I know that there are resources through that company regarding adolescent treatment.
We do have one more question. This one says, you mentioned the hormone change can trigger HAE. Does that mean HAE is more prevalent in the female patient?
Brett, you want to take that one?
Yeah, so this is true that during hormonal changes during puberty can increase the incidence or attack rate, or that's when a lot of patients will start to have their experience for HAE attacks. It's thought that maybe estrogen can stimulate activation of factor 12, and as Dr. Lumry had presented earlier, if you kind of look at the pathway, that's a setup for an HAE attack if that happens. Anyhow, but as far as the absolute number of patients, female to male, the females having more HAE, I don't think is really observed. I think it's similar. It's not a sex-linked trait. So with that aspect of the demographic or incidence of this condition.
Yeah, it's an autosomal dominant, not sex-linked, so it's 50-50 male to female. Women tend to have more frequent attacks than men do. In the HAE normal space, at least the one with the factor 12 gain of function mutation, oftentimes male patients with that mutation don't manifest swelling episodes, where women do, particularly at times when their estrogen levels may be increased. So there is a misrepresentation or an overrepresentation of women in clinical trials for this, because they tend to have more, if you will, severe disease, if you want to think about frequency of attacks, than men do. But as far as the actual transmission of the genetic mutation, it's 50-50.
I'm not seeing any more questions at this time, but I did want to thank you both for your expertise and insight tonight.
Thank you. I think we're right on time. Thank you all for joining us tonight. Really appreciate your interest in this topic. Thanks, Brett, for your excellent presentation.
Thank you, Dr. Lumry.